Good afternoon, everybody. Actually, I would start by presenting, so our patient and his parents are currently here. So he is a 4-year-old, almost 5-year-old now, presented with anemia and reticulocytopenia when he was 3 years old. His exam was significant for a mild hepatosplenomegaly and alopecia, and intermittent rashes here and there. Initial workup showed that his hemoglobin was 6.1, and his reticulocytes were low at 0.2%. His white cells and platelets otherwise were normal. His erythrocyte sedimentation rate, or ESR, was slightly elevated at 31, but this was also elevated in other occasions when he was not anemic, because sometimes it will be high with anemia. MCV, hemoglobin F were both normal, looking for Diamond-Blackfan anemia and other differentials. His viral workup, including parvovirus, was also negative. So because of the interesting past medical history that this patient has, we referred him to immunology before. And they did some basic workup, including T-cell subsets and immunophenotyping. And our patient had decreased B cells, NK cells, and elevated CD4 positive T cells. His immunoglobulins at that time of the presentation were normal, although he had history of low IgM and IgA that I will be talking about in his past medical history. Eventually, we did a bone marrow biopsy. That was normal cellular, but it showed the absence of erythroid precursors and mild eosinophilia with increased T lymphocyte aggregates. Given this presentation, we diagnosed him with Puret cell aplasia. So because it's usually acute and self-limited in pediatrics, we don't rush into treating those patients. So we observed him for 2 months, but he continued to be transfusion dependent. We tried a couple doses of IVIG 1 week apart, because some reports proves that it's efficacious, especially if it's parvovirus related, but this also did not work. High-dose steroids eventually was started, which is the first line for refractory Puret cell aplasia. Despite being on a high dose for a month, he did not have any response. So we initiated cyclosporin A and started weaning steroids. And for the first time, nicely, he responded to cyclosporin A, and he remained transfusion independent for about 6 months before he unfortunately relapses again. So at relapse, he presented with a hemoglobin of 6.1 again and reticulocytes of 0.4%. At that time, his platelets continued to be normal, but his white cells were mildly low, and that was mainly neutropenia. We did a bone marrow again, and that showed same findings of the original marrow, but also with decreased granulopoiesis. Thinking about MDS, given bone marrow failure, he may have a clonal risk of predisposition to cancers, but that was also negative. And we did parvovirus DNA PCR, which is the gold standard to rule out chronic parvo infection from the marrow, and that was also negative. After 2 immunosuppressant medications, we thought of MMF and then sirolimus, but neither of those corrected his anemia. So throughout all of his course, we did multiple other tests, including Diamond-Blackfan anemia genetic testing, Fanconi anemia genetic testing, and the autoimmune lymphoproliferative syndrome flow cytometry, and they were all unrevealing. So his past medical history actually was interesting. So before he presents with Puret cell aplasia, and actually since his birth, he had multiple issues. First issue was hemolytic anemia just after birth, and he required 1 or 2 blood transfusions before it corrects itself. We did not figure the etiology at that time. He had an immune thrombocytopenia, ITP, when he was 2 years of age. And that was managed with regular IVIG every 5 to 6 weeks. Neutropenia, which was intermittent just during the IVIG infusions, which is a common side effect. Alopecia areata, recurrent aphthous ulcers, which are impressive. Strabismus, recurrent fevers, with recurrent sinonasal infections, but he never had any serious infection. He had a history of low IgM and low IgA, and different rashes, including eczema and idiopathic urticaria at that time. And when you look at the graphs on the right, so this will summarize his course over the year or two. So you can see the first one, this is his hemoglobin. This is when he was mildly anemic, about 9 to 10, but he had iron deficiency at that time, and he required Venofer. This is when he presented with puretal aplasia, and this is cyclosporin put him into remission for the first time before he relapses again. And you can see how many blood transfusions he required with puretal aplasia and at relapse. This is his ANC, so he was intermittently neutropenic when he was getting the IVIG for ITP. And then when he relapsed with puretal aplasia, his presenting ANC was moderate, on the moderate side of neutropenia. But then soon after, his neutropenia continued to get worse, and it was below 100 actually. And you can see, which is an interesting finding, he had ITP from 2 years of age until 3 years of age when he presented with puretal aplasia. And at that time, his ITP cured, and he didn't have any thrombocytopenia after that. So now, thinking about all of this, there should be a unifying diagnosis with all those complaints that he had. So we sent the whole exome sequencing. While we are waiting for it, we kept looking for what may be causing this, and we came by this abstract from ASH last year by Dr. Sousa and Dr. Pertush. So when you read the title, adenosine deaminase 2 deficiency as a cause of puretal aplasia, mimicking Diamond-Blackfan anemia, so this is exactly what our patient had. And when you continue the abstract, you will see he fits the scenario about 80%. And not surprisingly, soon after, the whole exome sequencing came back, and that showed that he was compound heterozygous CSER1 with N370K from his mother and G358 from his father. And when we emailed Texas Children's, Dr. Sousa and Dr. Pertush about it, they directed us to Dr. Hirschfield to measure the ADA2 enzyme activity, and that was, as expected, low at 0.6. So now we have a diagnosis of deficiency of ADA2. So we moved to transplantation. So soon after this all came back, and it happened quickly. He continued to be transfusion dependent, but also his neutropenia, as I said, continued to get worse, and he was profoundly neutropenic for about 2 months. And that was the reason we moved to transplantation. So he had no siblings, so we did a matched unrelated donor, 10 out of 10 transplantation. He received fludarabine, melphalan, and intermediate Cambath, similar regimen that are usually used for macrophage activation and HLH patients, thinking that of the pathophysiology of M1 to M2 polarization, and that was a reduced intensity. He received methotrexate and tacro for GVH prophylaxis. So nicely, he engrafted his neutrophils 18 days after transplant, and his platelets 16 days later. His post-transplant course was, had few complications, but they were all manageable. So he had, this is an interesting complication, he had an intussusception at the time of engraftment. Its ilioileal was revealed by the ultrasound, but itself resolved with no intervention about 2 to 3 weeks later. Refractory thrombocytopenia, which we heard about in the previous presentations. So he had the GP2B3A antibody, which was suggestive of ITP. IVIG, high-dose IVIG didn't work. HLA-matched pooled platelets also did not work, and he continued to be thrombocytopenic. Rituximab was tried, but it also did not work. And eventually, sirolimus and romiplastim, weekly doses for about 10 or 11 doses, corrected his platelet count slowly. He had multiple infections, nothing serious. Coagulase, staph, Enterobacter, C. diff, diarrhea, rhinovirus, and just more recently, EBV viremia. Maculopapular rash that I will show you the picture that responded to topical steroids. The biopsy was not conclusive. And interestingly, this alopecia I was talking about before, pre-transplant, demonstrated hair regrowth after transplant. So I'll show you the picture. So this is one of the areas of the alopecia that he had before transplant. And this is the same area that showed hair regrowth. So transplant corrected that. And this is the rash he had, which was thought to be GVHD rash. So now to talk about his chimerisms and his ADA2 activity. This is the level we had pre-transplant, 0.6. At 1 month, 2 months, 3 months, and 6 months, about, after transplant, his chimerism continued to be 98%. And his ADA2 was corrected the first time at engraftment, and then it fluctuates, but it continues to be normal. Those were all done in Dr. Hirschfield lab. So apparently, we can end with thanking the patient and his parents, which we will meet soon. Dr. Dalal, my mentor through UH Rainbow Babies and Children's. The rest of my mentors, Dr. Sasa and Dr. Pertush from Texas Children's, and Dr. Hirschfield for running the ADA2 enzyme levels. The DADA2 Foundation, of course. Thank you.